With physician shortages projected at critical levels, part-time opportunities offer an attractive solution, allowing providers to step back from demanding schedules while contributing their expertise and serving in communities that need them most.
It's a fact that African Americans, Latinos, Native Americans, Pacific Rim people, and other minorities suffer from certain diseases at up to 5 times the rate of white Americans. Even though there are a number of underlying causes for these higher levels, doctors have identified 3 key areas that impact the quality of minority health: access to care, continuity of care, and cultural factors. The demographic changes that are anticipated over the next decade magnify the importance of addressing these disparities.
The Jefferson Reeves Health Center is a partnership between the Health Center's Board of Directors, the Miami-Dade County Health Department, the Public Health Trust, and the University of Miami School of Medicine.
There are several diseases. Diabetes and hypertension are probably the 2 most important. Also, HIV disease is probably more likely in minorities, as certainly that's what we see here in Miami-Dade County. There are other types of things that are not necessarily chronic illnesses, but injuries, motor vehicle accidents, lack of immunizations in children are often the case, and that's probably due to an access issue.
Hourly rates for part-time physicians and nurse practitioners depend on factors like geographic location, specialty, and years of experience.
We see a lot of hypertension, also diabetes. We see a lot of dyslipidemia, people with high cholesterol problems.
Minorities are affected by specific chronic conditions and diseases in a higher percentage compared to whites or even other minorities within groups. For example, one fairly well-studied situation is renal failure in African Americans or blacks, and this specifically in patients who have diabetes or hypertension. In that group specifically, renal failure is much higher than compared to other minorities.
The Department of Health and Human Services has selected 6 focus areas in which racial and ethnic minorities experience serious disparities in health access and outcomes: infant mortality, cancer screening and management, cardiovascular disease, diabetes, HIV infection, AIDS, immunizations.
How about language and culture? Are those factors?
I think it certainly is, especially for a Hispanic and the Haitian population. And if you're unable to communicate with them in their own language, you will often miss understanding those issues or not being able to put it into the whole picture of a diagnosis.
The children are so often used as translators for the parents, which is a tremendous, it's very bad for the children as well as for the doctors to understand.
In an underserved area in the multicultural city of Miami, the Jefferson Reeves Health Center is approaching treatment with an understanding of culture, custom, and language in what could be an example of how community involvement can benefit its minority groups. Being bilingual is a start.
Seguimos en español. Seguimos en español. Por supuesto, sí.
My ability to say a few words, for example, in Creole, and I'm fluent in English and Spanish, but I see a lot of Haitian patients in this health center. My ability to speak a few words in Creole does not make me an expert on the Haitian culture or Haitian American culture. And so language is a first and very important key that impacts on minority health, specifically the management of health issues, but it doesn't stop there.
HIPAA-compliant AI platforms now enable real-time translation during appointments. For example, the provider speaks English while a patient hears Spanish. AI assists in charting as well. This expands opportunities for English-only providers, reduces interpreter delays and overall costs.
Your culture is certainly at play in maybe not the incidence of the disease, but the way they are diagnosed or misdiagnosed, the way that the particular member of a minority group will seek treatment, and the perception of wellness versus disease. It is clearly true that people who come from different countries where preventive care is still a luxury or even a foreign concept, they will not do as well in illnesses, for example, things like glaucoma, dental illnesses, and diabetes. We know, for example, that half of the patients who have diabetes have been suffering from the disease for 5 years before they get diagnosed. It's the whole mindset of seeking preventive care.
Men, they don't like to come to the doctor, okay? So usually the wife, the mother brings them in, and they usually don't come freely.
In our culture also is a problem with the lending medications. The mother or the daughter or the sister, she has a stomach pain, it's similar to mine, take one of my pills. This is very dangerous, of course. When they come to us, we ask them to bring all the medications, and we assort them and put them all together, and then we see that they're taking 2 or 3 things that don't go alone, that they cannot be taken alone. We call the doctors, we explain that to them.
Part-time providers can appreciate a reduced workload and enjoy a longer professional journey.
Basically, getting together to diagnose the ills of a community and then start to addressing them, not only at the level of a doctor's visit. Because the doctor's visit is only basically 10 to 15 minutes in somebody's life.
There are hopeful signs with regard to Hispanic health. Smoking, drinking, and illicit drug use are less prevalent among Hispanics than among non-Hispanics. However, HIV/AIDS and diabetes are 2 of the most serious and troublesome health threats affecting the Latino population. On average, Hispanic Americans are almost twice as likely to have diabetes as non-Hispanic whites of similar age.
Illnesses aren't the only thing that we find. We also find some benefits. We know that in African Americans precisely there's a lower incidence of osteoporosis.
African American teenagers, for example, smoke less than their Caucasian counterpart.
First, they need to know the data. They need to know that they are at risk.
It has to go beyond the traditional means of education. For example, in the African American community, anything that's going to be done usually should be done with the support of the churches. And that's the reason why we do outreach programs where we bring the education to the churches. To take an example from the community I know very well, since I'm from Haiti myself, in the Haitian community, education has to be done through the radio. Radio is the medium of choice for educational programs.
Whether through bilingual skills or AI translation tools, your experience is a valuable asset to employers or partnerships in telemedicine, clinics, and hospitals.
People have to be interested in their own health, and that's clearly the first place to start. And when they don't know, then they need to find the information. Our libraries are filled with resource information. People who have access to computers now have extraordinary amounts of information available to them. The individuals in a community who are not well, who are sick, who can't work, who put stressors on our social service system, affects everybody. Those resources that could go to other projects wind up going to support people who are ill or who can't get appropriate services. And I believe very strongly that it is a community problem. It's not just an individual or a family problem. It really is the community's responsibility to help people get access to care.
One of the strengths, I think, of our local community is in fact its diversity. And to lose any part of that diversity, I think is a true loss. And so it becomes very important for us to take care of each individual ethnicity within the community and in context of the whole community.